Hi everyone, and welcome to our module on acid-base problems. So in the other modules on acid-base disorders, I talked about the rules for working up and evaluating acid-base cases, and in this module we're going to go through some actual cases and put those rules to use. So our first case is a 40-year-old man who presents to the emergency room with a 3-day history of severe diarrhea. Several coworkers have been ill with similar symptoms. An arterial blood gas is drawn showing a pH of 7.3, a PCO2 of 33. Electrolytes are a sodium of 134, a potassium of 2.9, a chloride of 108, and a bicarb of 16. And the question asks, what is the acid-base disorder? So at the top of the screen here, I've written the electrolyte values using the fishbone that we talked about how to use in the other module. And now I'm going to go through the case. So first of all, what you want to do when you're faced with an acid-base problem is read the stem carefully. There are usually clues to the acid-base disorder in the question stem. So they mention that the patient has diarrhea. So anyone who has diarrhea, we expect a non-anion gap metabolic acidosis. So that's what we're looking for. Also, there were no other clues to suggest a secondary disorder. So what we're anticipating here is a simple, straightforward non-anion gap metabolic acidosis. Now, there may be tricks involved, but it's important to know what you're looking for just based on the patient's description. The pH is 7.3, so that's low, which means we have an acidosis. So once we know we have an acidosis, we look at the bicarb and the CO2 to determine which type of acidosis it is. We have a bicarb of 16, which is low. Recall that 24 is a normal bicarb, so that means we have a metabolic acidosis. Anytime you have a low bicarb, you have a metabolic acidosis. We then look at the PCO2 and see that that's also low, and that means we have respiratory compensation. When both are abnormal in the same direction, meaning both are low or both are high, it means it's very unlikely you have a mixed respiratory and metabolic disorder. Because when you have a mixed respiratory and metabolic disorder, the numbers go in the opposite direction. For example, a low bicarb and a high PCO2 or vice versa. So here both numbers are abnormal in the same direction. They're both low, so a mixed disorder is unlikely. We check the anion gap because anytime you have a metabolic acidosis, you have to check the anion gap, and it's 134 minus 108 minus 16, which is 10, and that's normal. Normal is less than 12. Now, anytime you have a metabolic acidosis, it doesn't matter what kind, you use Winner's formula to determine the expected PCO2. So now we're going to use Winner's formula. The PCO2 expected based on Winner's formula is 1.5 times the bicarb plus 8 plus or minus 2. So that's 1.5 times 16 plus 8, or 32 plus or minus 2. So we should have a CO2 anywhere from 30 to 34 if we're going to have normal compensation, and we do. Our PCO2 is 33. So this is a simple non-anion gap metabolic acidosis with no secondary disorder. Case 2 is an 80-year-old man with a severe cardiomyopathy who presents with shortness of breath and edema for 2 days. An arterial blood gas is drawn showing a pH of 7.25 and a PCO2 of 62. Electrolytes show a bicarb of 27, and the question asks, what is the acid-base disorder? So they tell us that the patient has a CHF exacerbation, so we expect an acute respiratory acidosis. Anytime there's a problem with breathing, whether it's heart failure or pneumonia or asthma, the disorder that you expect is a respiratory acidosis from retention of carbon dioxide. The pH is 7.25, so this is an acidosis, and then we go and look at the PCO2 and bicarb. The PCO2 is high at 62. Recall that normal is about 40, so this is a respiratory acidosis. Next, we look at the bicarb, and it's also high at 27. Normal is about 24, so we have metabolic compensation. And both the CO2 and bicarb are abnormal in the same direction. They're both high, so when they're abnormal in the same direction, it makes a mixed respiratory and metabolic disorder less likely. Next, we check to see that the compensation is appropriate, and recall from the other acid-base module that I told you acute respiratory acidosis produces a compensation in bicarb of an increase of 1 for every 10-point increase in CO2. So we would expect the bicarb to be about 2 points higher, a bicarb of 26. Our PCO2 has gone from 40, which is normal, up to 62. So that's an increase of about 20. So therefore we expect a 2 increase in the bicarb. So the bicarb should go from 24 to about 26. And it's 27, so it's very close. So we can conclude that there is no concurrent disorder. So this is a simple acute respiratory acidosis due to congestive heart failure with no concurrent or mixed disorder. The next case is a 40-year-old woman with rheumatoid arthritis who presents for a routine exam. She has normal vitals and a normal physical exam. She was hospitalized for a kidney stone 6 months ago, which has since resolved. Serum electrolytes show a sodium of 140, a potassium of 3.4, a chloride of 110, and a bicarb of 16. Because of the low bicarb, an arterial blood gas is done showing a pH of 7.25 and a PCO2 of 32. And the question asks, what is the acid-base disorder? So once again, I've drawn the electrolytes up here to remind you. So this patient's pH is 7.25, so she has an acidosis. The bicarbonate level is low at 16. Recall that normal is 24, so this is a metabolic acidosis. The PCO2 is also low at 32. Recall that normal is 40, so there's respiratory compensation. We can determine the expected PCO2 from Winner's formula, and I've done that for you here. I'm not going to go through all the math for that again, but the expected PCO2 is 32, and that matches our actual PCO2. So we do not have a secondary or mixed respiratory disorder along with the metabolic acidosis. Once you find out that you have a metabolic acidosis, you have to calculate the anion gap, and this person's anion gap is 140 minus 110 minus 16, which is 14, and normal is about 12, so this is pretty close to normal. So this is a non-anion gap metabolic acidosis. But the question we haven't answered yet is, why does she have a metabolic acidosis? And we have to consider that this person may have a type 1 renal tubular acidosis given her history of rheumatoid arthritis and kidney stones. Rheumatoid arthritis and kidney stones are both classic for patients with a type 1 RTA. And we talked about this in the other module on acid-base disorders, but anytime you're faced with a non-anion gap metabolic acidosis, the two tests you want to check are a urine anion gap and potentially an acid challenge. So in a urine anion gap, you measure the urinary levels of sodium, potassium, and chloride, and you calculate the urine anion gap by adding sodium and potassium and subtracting chloride. You should get a negative value because of the acidosis. However, in patients with an RTA, it will be positive. So this patient should have a urine anion gap check next. In addition, you may want to do an acid challenge test where you administer ammonia chloride. The urine pH will remain greater than 5.3 after ammonia chloride administration in patients with a type 1 RTA because they cannot acidify the urine. If you're confused about this, go back to the module on renal tubular acidosis and take a look at that. But the most important thing to remember is that for patients with a non-anion gap metabolic acidosis, urinary anion gap and acid challenge are the two tests that can help you sort out the etiology. The next case is a 75-year-old man who has long-standing history of severe COPD for which he requires chronic oxygen therapy. Serum electrolytes show a sodium of 140, a potassium of 4, a chloride of 94, and a bicarb of 34. An arterial blood gas is done and the pH is 7.32 and the PCO2 is 69. What is the acid-base disorder? So the pH is 7.32, so we know we have an acidosis. The PCO2 is high at 69. Recall that normal is 40, so we have a respiratory acidosis. The bicarbonate level is also high at 34. Recall that normal is 24, so this is metabolic compensation. Based on the question stem, this is a chronic respiratory acidosis. We have no reason to believe this is acute. They describe this patient as a man with long-standing COPD. So we believe this is a chronic respiratory acidosis, so we're going to use the chronic compensation equations that I talked about in the other modules. So for chronic respiratory acidosis, the expected change in bicarbonate is 3.5 times the change in PCO2 over 10. Well, the change in PCO2 is 69, which is the patient's PCO2, minus normal of 40, or 29. That's our change in PCO2. So the expected change in bicarbonate is 3.5 times 29 divided by 10, and that works out to be 10. Our actual change in bicarbonate is 34, which is the patient's bicarbonate, minus 24, which is a normal bicarbonate, and that is also 10. So our actual and our expected are equal to one another, so we do not have a mixed disorder. This is a chronic respiratory acidosis. And this example here is something that you will see again and again in your clinical rotations. Patients with long-standing COPD chronically retain PCO2 and therefore they have a chronically elevated bicarb. So when you check chemistries on your COPD patients who come into the ER, you will always find an increased level of bicarbonate like what I've shown up here, and that's from chronic retention of carbon dioxide. Case 5 is a 50-year-old man who is found obtunded and poorly responsive. An arterial blood gas is drawn showing a pH of 7.52 and a PCO2 of 47. Electrolytes show a sodium of 140, a chloride of 96, and a bicarb of 34. What is the acid-base disorder? So let's go through the numbers. The pH is 7.52 and that's high, so we have an alkalosis. The bicarbonate is 34 and that's also high. Recall that normal is 24, so this is a metabolic alkalosis. The PCO2 is also high at 47, so this is respiratory compensation. And they're both abnormal in the same direction. They're both high, so a mixed disorder is less likely. But still we're going to check to make sure the respiratory compensation is appropriate. So the equation for appropriate respiratory compensation in a metabolic alkalosis is the change in PCO2 should be 0.7 times the change in bicarb. Well, the change in PCO2 for this patient is the patient's PCO2 of 47 minus normal of 40, and that is 7. The change in bicarb for this patient is the patient's bicarb of 34 minus a normal of 24, and that is 10. So the expected change in PCO2 is 0.7 times 10, or 7. So you can see that the expected PCO2 change and the actual are equal, so we do not have a mixed disorder. This is a pure metabolic alkalosis. But the question we still haven't answered is, what is the cause of this man's metabolic alkalosis? Recall that there's a short list of causes of metabolic alkalosis. These include a contraction alkalosis, hypokalemia, diuretics, vomiting, hyperaldosteronism, and antacid use. And one of the most helpful pieces of data in a metabolic alkalosis is the volume status of the patient. So we want to know, does this man have dry skin and dry mucous membranes? Because if he appears dehydrated, then the cause is most likely a contraction alkalosis or diuretics or vomiting. Another very helpful piece of data in an unknown caused metabolic alkalosis is the urinary chloride, because recall from our module on acid-base disorders that when you have GI losses of volume that cause a metabolic alkalosis, the urinary chloride gets low. That's what happens when you have vomiting. Most metabolic alkalosis problems get better when you give saline. They're called fluid responsive. The only ones that don't are hyperaldosteronism and hypokalemia. All the others essentially resolve when you administer saline. Case 6 is a 59-year-old man with a history of alcoholism and depression who presents with altered mental status. He was found by his ex-wife sleeping in his tool shed. He reports blurry vision and black spots. An arterial blood gas is drawn. The pH is 7.3. The PCO2 is 28. The electrolytes show a sodium of 141, a chloride of 102, and a bicarb of 14. What is the acid-base disorder? So the pH is 7.3, which is low, so we have an acidosis, and the bicarbonate is 14, so it's a metabolic acidosis. We then see that the PCO2 is low at 28, so this is respiratory compensation. And then using Winter's formula, we find that the expected PCO2 is 29 plus or minus 2. I've shown the math for that over here in the corner if you want to review it. So our actual PCO2 is within the range predicted by Winter's formula, so we do not have a secondary respiratory disorder. Next thing we do with a metabolic acidosis is calculate the anion gap. So that's 141 minus 102 minus 14, which is 25, and that's high. Now, anytime you have an anion gap metabolic acidosis, you need to calculate the delta-delta to make sure there isn't a concomitant metabolic disorder. The Winter's formula tells you there's no concomitant respiratory disorder. That's what we've done up here. But the delta-delta is going to help us rule out that we don't have a concomitant metabolic alkalosis or non-anion gap metabolic acidosis. So let's calculate the delta-delta ratio. The delta anion gap is the patient's anion gap minus a normal gap, which is 12, so that's 13. The delta bicarb is a normal bicarb, which is 24, minus the patient's bicarb of 14, which is 10. So therefore, the delta-delta ratio is 13 over 10, which is 1.3. And in the other modules on acid-base disorders, I discussed that a delta-delta from 1 to 2 is normal, and this rules out that there is a second disorder. We have determined that there's no secondary metabolic disorder using the delta-delta ratio. So this is a simple, pure anion gap metabolic acidosis. And you should know, based on the question stem, that this is most likely due to methanol intoxication. This man was depressed. He was found in his tool shed where he may have had access to methanol and may have had a suicide attempt. He also reported vision problems. So when you see vision problems associated with an anion gap metabolic acidosis, you should think of methanol intoxication. Case 7 is a 50-year-old man with diabetes who presents to the emergency room with confusion. His wife said he has been thirsty and urinating frequently. In addition, he takes narcotics for back pain, and she believes he has been taking more pills than usual lately for abdominal pain. An arterial blood gas is drawn showing a pH of 7.28, a PCO2 of 40. Electrolytes are sodium 134, potassium 3.5, chloride 94, and bicarb 12. What is the acid-base disorder? So there are some very helpful clues in the question stem for this case. The patient is diabetic with polyuria, polydipsia, and abdominal pain. So all that paints a picture of DKA. And in diabetic ketoacidosis, we expect an anion gap metabolic acidosis. Also, they tell us that this man's been using narcotics, and narcotics can cause respiratory depression and create a respiratory acidosis. So just based on the question stem, we are already concerned that maybe we're going to have an anion gap metabolic acidosis complicated by a secondary respiratory acidosis. So let's go through the numbers. The pH is 7.28, which is low, so we have an acidosis. The bicarb is 12, which is low, so we have a metabolic acidosis. And then the PCO2 is 40, which is normal. So right away something is wrong. We'll use Winner's formula to check this PCO2 in a minute, but I can already tell you it's not going to meet our expectations because it is normal. You should always have a low PCO2 in the setting of a metabolic acidosis. This man does not have respiratory compensation, so something is wrong. And then finally, we do the anion gap anytime we see a metabolic acidosis. And for this patient, it's 134 minus 94 minus 12, which is 28, so that's high, meaning we have an anion gap metabolic acidosis. So we'll use Winner's formula to check the PCO2, and we find that the expected PCO2 is 26. I've shown the math for that down here if you want to review it. So our PCO2 is higher than expected at 40, so there is a concomitant respiratory acidosis. And remember, you can use Winner's formula to prove this to yourself, but already you know that a normal PCO2 in the setting of an acidosis is a problem. It should never be normal. So we have an anion gap metabolic acidosis combined with a respiratory acidosis. The anion gap acidosis is coming from DKA, and the respiratory acidosis is coming from hypoventilation, most likely related to respiratory depression from the narcotics that this patient has been taking. Last case is a 60-year-old woman who presents to the emergency room with massive vomiting for 3 days. On exam, she's hypotensive and tachycardic. Skin turgor is diminished. An arterial blood gas is drawn showing a pH of 7.24 and a PCO2 of 24. Electrolytes are sodium of 140, potassium of 3.2, chloride of 79, and bicarb of 10. What is the acid-base disorder? So once again, we've got to look carefully at that question stem. She's been vomiting, so we expect a metabolic alkalosis. She also is dehydrated. Anytime you see a severely dehydrated person, especially someone who may be in shock, you have to wonder if there's going to also be a lactic acidosis, which would give an anion gap metabolic acidosis. So let's look at the numbers. The pH is 7.24, so there is an acidosis. The bicarbonate level is low, so there's a metabolic acidosis. The PCO2 is also low at 24, so there's respiratory compensation. Because they're abnormal in the same direction, a mixed metabolic and respiratory disorder is less likely. The anion gap is 140 minus 79 minus 10, which is 51, which is very high, so we have an anion gap metabolic acidosis. So we can use Winner's formula to determine the expected PCO2, and I've shown the math for that over here. The expected PCO2 is 23 plus or minus 2. Now our actual PCO2 is 24, so this tells us that we have normal respiratory compensation and we do not have a concomitant respiratory acid-base problem. Now this is an anion gap metabolic acidosis, so anytime you have an anion gap metabolic acidosis, you need to rule out that you don't have a second metabolic acid-base problem, and you do that using the delta-delta ratio. So the delta anion gap for this patient is 51. It's the patient's anion gap minus a normal gap of 12, and that's 39. The delta bicarb for this patient is a normal bicarb of 24 minus the patient's bicarb of 10, and that's 14. So the delta-delta ratio is 39 over 14, which is 2.8, and that is high. And we discussed this in the other modules on acid-base disorders, but when you have a delta-delta ratio greater than 2, it means you have a concurrent metabolic alkalosis, which is what this patient has from vomiting. So this is an anion gap metabolic acidosis from lactic acidosis with a concomitant metabolic alkalosis from vomiting, and this is actually a very common clinical scenario that you can see in the hospital. So let me finish up with a summary of what we've seen in this module. We saw a case of diarrhea with a simple non-anion gap metabolic acidosis. That's a very basic acid-base problem that you should be able to solve. We saw an acute respiratory acidosis, and you should recognize that the CO2 goes up in acute respiratory problems, giving you an acidosis. We saw renal tubular acidosis, and remember that in these problems the urine anion gap is very helpful, and you should recognize question stems for RTA patients with things like kidney stones and autoimmune diseases. We saw chronic respiratory acidosis in a COPD, or a very classic clinical scenario where COPDers retain carbon dioxide and walk around with a very high level of bicarb from renal compensation. We saw a metabolic alkalosis of unknown cause, and we've reminded everyone that you want to know the volume status and the urinary chloride in those situations to determine the etiology. We saw methanol toxicity, which remember gives you an anion gap metabolic acidosis with vision problems. And then finally, we did two mixed disorders. The first was an anion gap metabolic acidosis with a concomitant respiratory acidosis. And in these situations, Winner's formula doesn't match, and that's how you can recognize them. And then the last question was a patient with a metabolic acidosis and a metabolic alkalosis, and this is where the delta-delta was abnormal. So these are 8 pretty standard bread and butter type of acid-base problems. If you had trouble with them, go back to the modules on basics of acid-base physiology and then watch this module again and make sure you understand how to solve all the problems. And that concludes our module on acid-base problems.